What is the three-step approach for diagnosing or making a confirmation of diagnosis of hemophilia? Why in hemophilia we get normal platelet count, normal prothrombin time, normal thrombin time, TT, but prolonged activated partial thromboplastin time, APTT? What is the mixing study done for hemophilia patient? What is the purpose of this? All these things actually we are going to discuss in this short session, which is basically targeting to simplify the ideas and the concept of laboratory diagnosis of hemophilia. Now, the first thing I want to tell you that you need to understand that hemophilia is essentially nothing but a disorder of intrinsic coagulation pathway. You know, in hemostasis, which is a process to stop the bleeding, because hemo means blood and stasis means stopping. So we know that whenever we start to bleed, there is a process there, physiologic process there, which stops bleeding. That is called hemostasis. Mind it, this is hemostasis, not homeostasis. Homeostasis is a different thing, like glucose homeostasis, which maintains the balanced of various things. So here I sidetracked actually. Let us focus on the hemostasis. Hemostasis is not homeostasis, but hemostasis. Hemostasis are in two steps: primary hemostasis and secondary hemostasis. Primary hemostasis, what is done, that we usually form platelet plugs to stop the bleeding, and secondary hemostasis usually can occur by intrinsic coagulation pathway and extrinsic coagulation pathway, which merge into final common pathway. So if you look at the hemophilia, there are three kinds of hemophilia are there: hemophilia A, hemophilia B, hemophilia C. Hemophilia B, A, which is the most common subtype, occurs due to inherited factor VIII deficiency. Hemophilia B, which is also known as Christmas disease, because the first patient's name was Christmas, Stephen Christmas, or royal disease, it usually occurs due to factor IX deficiency. And hemophilia C, which is the rarest form, uncommonly seen, typically seen in Ashkenazi Jews, this occurs due to factor XI deficiency. And hemophilia C is an autosomal recessive disorder, unlike the hemophilia A and B, which are X-linked recessive disorder. Now the point is that if you know that the three factors which are deficient in the hemophilia A, B and C respectively, which is factor VIII, factor IX and factor XI, all of them, they are part of the intrinsic coagulation pathway, because you know that intrinsic coagulation pathway basically starts with 12, then 11, then 9 along with 8, and then starts the final common pathway 10, 5, 2, 1, half of that, because 10's half is 5, 5 halves is 2.5 and 1. This way you can remember that also. And in this side there is 7 plus 3, they say commonly. There is 7 means the factor 7 plus tissue factor, which is also called factor 3. So they make the merge into the final common pathway 10, 5 to 1. But basically both the intrinsic and extrinsic coagulation pathway, they want to activate factor 10. Factor 10 is the pathways are actually like a Y, and the fulcrum of the Y is the factor 10, because both intrinsic coagulation pathway and extrinsic coagulation pathway, they want to activate factor 10. Intrinsic coagulation pathway is activating factor 10 by these steps: factor 12, factor 11, factor 9 along with 8, then they are activating factor 10. On the other side, extrinsic coagulation pathway, they are activating factor 7 along with tissue factor, they are activating factor 10, and then the final common pathway starts. Now let us go back to what is hemophilia. Hemophilia, as I mentioned, it is of three flavors, and it can occur due to either factor VIII deficiency, inherited factor VIII deficiency. It's not any factor VIII deficiency, it must be a genetically inherited factor VIII deficiency, then only it is hemophilia A. Hemophilia B is factor IX deficiency, and hemophilia C is due to factor XI deficiency. So 8, 9 and 11, if you look at that pathway, coagulation pathway, 8, 9, 11, all of them, they come under the intrinsic coagulation pathway. So the basic fundamental concept is this, that hemophilia is nothing but a disorder of intrinsic coagulation pathway. So in the hemostasis, it's a problem not of primary hemostasis but of secondary hemostasis, that means coagulation pathway. And in the secondary hemostasis, it's a problem of intrinsic coagulation pathway. If you understand this, then the result to interpret the results of the screening test becomes very simple, because primary hemostasis basically test platelet numbers and platelet functions, because this abnormality can cause problem in primary hemostasis. So they are called quantitative platelet disorder, which is thrombocytopenia mostly. That means quantity wise platelet is less. That's why Penia was the Greek goddess of poverty. So if there is a less number of platelet, that would cause bleeding. And if there is a functional platelet disorder, like some rare ones, Bernard-Soulier syndrome, Glanzmann's thrombocythemia, these are the functional platelet disorder which can also cause bleeding. So hemophilia is neither a problem of low platelet count nor a problem of platelet function. It's a problem of inherited factor deficiencies of coagulation factor 8 or 9 or 11. So obviously platelet count would be normal in the hemophilia because this is not a problem of primary hemostasis. Platelet function would be normal in the hemophilia because this is not a problem of, this is not a functional platelet defect. So it's not a problem of primary hemostasis. That's why platelet count or function would be normal in hemophilia. Now let us focus on the secondary hemostasis, coagulation pathways. Coagulation pathway, as I mentioned, this is particularly a problem of intrinsic coagulation pathway. Now intrinsic coagulation pathway basically is assessed by activated partial thromboplastin time, APTT. Now APTT, that's why APTT would be abnormal or abnormally prolonged in the patient with hemophilia, because hemophilia is a problem of the intrinsic coagulation pathway, and all the components which are defective or deficient in the hemophilia patient, they are part of the intrinsic coagulation pathway. This is a fundamental concept actually. An intrinsic coagulation pathway is assessed by activated partial thromboplastin time. So that's why the PT, prothrombin time, would be normal in this patient. Prothrombin time would be normal in this patient because this is not a problem of extrinsic coagulation pathway. This is typically a problem of intrinsic coagulation pathway. So now I know that platelet would be normal, count would be normal, platelet function would be normal. As it is not a problem of extrinsic coagulation pathway, prothrombin time would be normal. As there is no problem in the conversion of fibrinogen to fibrin, thrombin time would be normal in this condition. But the only abnormality would be isolated prolonged APTT on the screening test. Why APTT? Because there is a problem of the intrinsic coagulation pathway. Now, after the screening test is done, I told you there are 3-step approach actually in the diagnosis of hemophilia. So these are actually screening tests, PT, APTT, platelet count, all these things, thrombin time. After this, another test is done. If we get that the patient has prolonged APTT, activated partial thromboplastin time, normally it is around 25 to 35 seconds. So in a patient with hemophilia, you get much more prolonged than that, maybe 55, 65 seconds, depending on the severity of the deficiency. Next step is done is called mixing study. In mixing study, what is done, that the patient's plasma is basically mixed with normal patient plasma. That's why mixing is called. And we want to check that mixing normal patient's plasma is correcting the APTT or not. If it corrects in the APTT, it basically means that the patient's plasma was deficient with something. That's why it got corrected as we mix with the normal pool plasma with that. I'll be talking separately on mixing studies in a separate session because it needs a detailed discussion. So the next step is basically done, the mixing study, and its basic purpose is basically to figure it out that it is truly a factor deficiency or there is an inhibitor of the factor. Sometimes the patients can have factor 8 deficiency, factor 9 deficiency because they develop inhibitors against them, understand? Inhibitors against the factor 8. So that is the basic purpose of doing mixing studies. As I mentioned, I would discuss it in a separate study because it needs a separate prolonged discussion. So first step is this screening study. Next is the mixing study. Mixing study is basically telling you, confirming you that definitely there is a problem of the factor deficiency. Now APTT would be prolonged and PT would be normal in both factor 8 deficiency and factor 9 deficiency. That means both due to factor hemophilia A or hemophilia B. And to pinpoint the exact cause, what you need to do, you basically need to do a specific factor assay. So if the specific factor assay, like chromogen based assay, if a specific factor assay factor 8 becomes low, then it is specific for hemophilia A. If a specific factor assay factor 9 becomes low, then it is becomes specific for hemophilia B. That is the idea. This is a 3-step approach in this. Because all these things, the screening tests like PT, APTT prolongation will be seen in both hemophilia A and B. They cannot differentiate hemophilia A and B on this purpose. I'll continue further on this session on how to, on the laboratory diagnosis of the hemophilia in the coming sessions. Thank you so much.